morning, team. It is Sunday morning. I'm actually about to do a podcast with a friend who invited me to be on her podcast, which is always fun. And I have like 6 minutes. So I am going to talk about cervical exams because a lot of people ask, do I need a cervical exam? Why do I need a cervical exam? And someone actually recently asked, am I legally allowed to decline a cervical exam? So I'm going to separate these a little bit into two different times you would have a cervical exam in pregnancy. Okay, so one is towards the end of the pregnancy. Let's say you're 35, 36 weeks. I don't like to say old-fashioned, but for lack of a better word, the old-fashioned times, women were checked weekly, starting at 35 or 36 weeks, to see if they were dilated. Okay, I think maybe people didn't know better. I don't know. Actually, I really don't know the history of the teaching there. But many of us, and I will speak for myself and the doctors in my practice, don't do that anymore. Meaning we do not do routine cervical exams after 35 or 36 weeks for patients. Now, are there some doctors who still do it? Probably yes. In fact, for sure, yes, I hear it. And I don't want to say that they're being old-fashioned or they're doing anything wrong. I'm merely going to say my thoughts on this. My thoughts are that many of us are taught in medicine to only do something that will change the course of action next, right? I should do a test. I should do some intervention that is necessary, not only to either improve care or to be able to alter my care. So let's say I check your cervix at 36 weeks or 37 or 38 or 39 or literally on your due date or a week past your due date. Here's what I can tell you. Are you dilated? Are you effaced, which is how soft? Where is your cervix? Is it very far forward, which is what will happen closer to labor? Or is it still super far back behind, like kind of closer to your sacrum? How high is the head? And I can glean a little bit of information about your pelvis and kind of the shape and maybe the space of your pelvis. But does any of that predict when you're going to go into labor or if you're going to deliver vaginally even? I would say no, and maybe yes. No, meaning I could check you today on your due date or a week past, and you could be 3 centimeters dilated and not go into labor. Or today at 36 weeks, you could be walking around 2 to 3 centimeters dilated, especially if it's your second baby, and not go into labor for weeks. Or I could check and say, oh, your cervix is rock hard and closed and really far away and really far back, which are terms we use. And guess what? You break your water that night or you go into labor that night. So there's nothing from a temporal relation, there's no predictive ability from checking a cervix to tell you when you're going to go into labor. Now, the caveat would be like if you're contracting, and I check you and I say, oh, it feels like you're just still, let's say 2 to 3 centimeters and 80% thinned out, you're probably still in early labor and you're going to end up going into labor in the next several hours. But even then, I give patients a span. I'll say like in the next 1 to 2 days, things might progress. Sometimes it's next hour they come back to the hospital or to my office, and other times it's literally 2 or 3 days. So again, to me and to many of us, there is no value in checking your cervix weekly because it's not going to help predict. Now, sometimes at 36 weeks, because we do the beta strep culture, that vaginal perineal culture that we do to see if you have that beta strep bacteria, at that point, because you're already there, sometimes patients will say, hey, are you going to check me? Or sometimes the doctor might offer. I actually don't usually even offer. I usually say, I'll check if you want, but by the way, you're probably not going to want me to check you more than once because it's very uncomfortable and it doesn't help predict. And honestly, most patients don't even know that because I haven't had the time to have this conversation with every single patient. And many patients, especially if they're there with their moms, back in the pre-COVID days when moms used to come in for a lot of the visits, the moms would say, you mean you're not going to check me every week? You're not going to check my daughter every week? And I would always kind of retort, well, tell me what happened when you got checked. 99% of the time, the moms would say, you know, you're right. They checked me that day and said I was closed and I went into labor that day. Or they checked me and said I was 3 centimeters dilated, but I walked around that way for 4 weeks. So again, there is no value in the absence of labor or bleeding or some other reason that we need to check you. There's no value in just routine cervical checks prior to you actually needing them when you're in labor because it doesn't help predict. Now, what about your pelvis? Didn't they used to do assessments of the pelvis to see if someone could deliver a baby? Well, yes, they used to actually do clinical pelvimetry, which is where they would have different ways of measuring, or x-ray pelvimetry, where they would actually x-ray a woman's pelvis to do these measurements to try to predict if the head was going to come out. as you might guess, it wasn't found to be so accurate. I've definitely had times, not frequently, where I'll check someone's pelvis and think, ain't no baby coming out of that pelvis. Lo and behold, 2 days later, that woman is pushing out a kid, right? On the other hand, I would say most of us clinicians who've been in practice long enough can generally assess, like, what do we think is going to happen? And we're not always right, but we're probably close to right if we feel a very kind of contracted pelvis with a certain shape, or if the baby's head is incredibly high up and not even close to the pelvis. Yet we've all seen that during labor, things can change because of the effect of the hormones on all the ligaments. So again, do you need a cervical exam? In my humble opinion, prior to being in labor, no, you don't. Save for if you'd like to know, save for if you have bleeding or we think you're in early labor, or if we're trying to predict what medications we might use when you are going to be induced, then it might be valuable to do before you actually go to the hospital for the induction. Those are the times I would say you need it. Now, do you have the right to decline? Of course. I mean, you always have the right to decline. Though I guess I would offer, like, think about why you're declining. Meaning, is your doctor saying, I really think I need to check you because you've had XYZ symptoms, in which case you're kind of asserting your right as the patient to decline? I would personally say maybe that's not wise. Now, if you feel that your doctor's being aggressive and just doing something for no reason, then forget declining. That is a reason to go see a different doctor. That's a completely different story. But yes, the answer is you always have the right to decline. It is your body and you get to choose what you need. Now, what you need is not something you always know. So appreciate the fact that you should have a collaborative relationship with your doctor before you just kind of decline, right? If you have that type of relationship where you feel like you have to assert your need to decline, then I would suggest finding a different practitioner more than continuously thinking about your ability to assert the declination. Does that make sense? Okay, what would be another time to check? Let's say you're close to the end, like you're 39 weeks, and you would like to have your membranes stripped. That is something, some people call it membrane sweeping, membrane scraping, which I hate the word, or membrane stripped, which just basically means if the cervix is a little bit open, the doctor or nurse or midwife can put her finger inside. On the other side of that cervix is the membrane, the amniotic membrane, the balloon the baby's in. And we can put our finger there and just gently kind of push away and essentially detach where the balloon, the membrane, is attached to the inside of the uterine wall. And by gently separating that just a couple of, millimeters or a centimeter or two, like in that circumference around there, you're not particularly stretching the cervix out, you're pushing away the membranes and detaching them from where they are attached to the uterus. That releases prostaglandin, and prostaglandin is the hormone that can help put you into labor and stimulate your cervix to thin out. So that can be one form, just like nipple stimulation or bowel stimulation, of actually getting you into labor. Okay, I hope that helps. Happy Sunday.